We're just opening up formally to everyone. Please welcome to our TBPPM webinar, the first one of 2024. Really happy to see all of you joining today. It's an early morning. We're starting on a very exciting topic, quality of TB care, and we're looking at standardized patient studies, which is a very important tool that informs us more about the quality of TB care. And I'm really pleased that we have an excellent panel. You see some of them already. I'm just looking for Lauren in our list to promote her to panelist. So that's hopefully she has now. So she will join our panel too. I'm sorry. That was just 1 minute. I am looking at the list and there's Lauren. Great. So we're ready to start. Thank you all for joining. We have a 75-minute webinar in front of us for this morning. It's morning in Ottawa. I know you're joining from different parts around the world, so very pleased that you're all here with us. Please use the Q&A, that's the button in the bottom, for asking any questions for any of our panel members. They will make an effort to look at the questions also during presentations and get back to you. So if you have a specific questions to any of the presenters, please feel free to write any questions in the Q&A. You can use the chat as well, but we use the Q&A really for questions. If you need transcription, you can also use that. We've enabled that service, so you can use that for yourself to get the subtitles. That's it for the logistical things. We have a fantastic panel, and I am very happy that we have two wonderful moderators who are well equipped to guide us through this topic. First of all, I would like to introduce Ada Kwan. She's a health economist in the University of California in San Francisco, and she's a postdoc there. She has a lot of experience in doing various research topics around the world, including standardized patient studies. And she is going to guide us through introducing our various panel members and guide the discussion. So thank you so much for joining, Ada, this morning. It's very early for you, I know. And then secondly, we have Lauren Rosapap. She's the Associate Director at Results. Sorry, I missed that. Sorry, Lauren. She's currently the Associate Director for Evaluation and Adaptive Learning at Results for Development. And she has over 15 years of experience as a researcher and an evaluator in the US government. And she's also been involved in several of the SP studies. And she will be, together with Ada, moderating this discussion and guiding us through all the questions that you have. So with that, I am going to hand over to the experts who really know more about this topic. And I'm looking forward to hearing from our wonderful speakers. Ada, the floor is over to you. Thank you.
Thanks, Petra, so much. Hi, everyone. Good morning, afternoon, evening, whatever time it may be where you're joining us. Again, my name is Ada Kwan, and I'm very happy to be here today. So this webinar is on one of my favorite topics, quality of care and how to measure it. So, and we all know what doesn't get measured cannot be improved. So as we proceed, I first want to highlight the World Health Organization's definition of quality of care to level set us all. So WHO defines quality of care as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes. It is based on evidence-based professional knowledge, and it is critical for achieving universal healthcare coverage. So that's what WHO says about quality. And for tuberculosis, as you will all know, quality is crucial because low quality can mean misdiagnosis, undertreatment, or overtreatment, or all three of those care outcomes for a single person in a single visit to the healthcare facility. So low quality has a variety of repercussions for TB, extending beyond individuals too, to their households and communities. So how can quality be measured to be improved in such a case? Here's where the standardized patient or SP method comes in, the topic for today. So what is the SP method? It's a pretty innovative and unique approach for measuring quality. And so those on the panel today have participated in a variety of studies and projects that have utilized the standardized patient method for understanding TB care quality specifically. So our distinguished speakers, they're going to tell us much more about the SP method, how to conduct and interpret these studies with a focus on TB. You'll hear from them about work highlighting the COVET study, which utilized mixed methods with standardized patient surveys to elucidate what is happening with TB services across India, Indonesia, and Nigeria. And the study was conducted between 2021 to 2023. So speaker bios for today's webinar will be shared online in the webinar report, as well as on the website. So just to remind you of that, I'm going to put the website link in the chat right there. And for presentations, we have Benjamin Daniels starting us off. He's going to present on challenges and nuances of conducting SP studies in private healthcare settings. Benjamin is a research fellow at Georgetown University, and he's supported some of the largest research studies to date utilizing clinical vignettes, provider observation, and standardized patients. All of these methods that highlight the importance of measuring healthcare provider knowledge, effort, and practice. Following that, we'll hear from Dr. Boni Lestari. She's going to share insights into specific findings from SP studies conducted in Indonesia, offering a contextualized perspective. Dr. Boni is a medical doctor and clinical epidemiologist based at Universitas Padjat Jarum. Her career is decorated with 19 years of working experience, wearing many hats from clinician, public health practitioner, researcher, and lecturer in the context of health programs. Excuse me. After Dr. Boni, Angelina Sassi, will guide us through the critical task of interpreting SP studies, providing invaluable insights into informing quality of care and understanding provider perspectives at the same time. Angelina is currently a research assistant at McGill University, where she completed recently a master's in epidemiology. So she has supported SP studies in Indonesia and Nigeria, as well as supported other large-scale quality improvement initiatives. So this webinar is not just about information delivery. So we are here to also engage with you, our audience, and a reminder to participate actively through the chat feature. Following the presentations, we've reserved 15 minutes for Q&A. Our esteemed moderator for this segment will be Lauren Rosapep. And so thanks for joining us. And so I will now turn it over to you, Ben, to start.
Thank you very much, Ada. So like Ada said, my name is Benjamin Daniels. I've been working in this field for about 10 years now, focusing on direct measurement of how healthcare gets delivered from providers, beginning with the development of knowledge, translating into effort in the clinical setting, and finally ending with measuring the delivered quality of care using methods like standardized patients. So I'm going to take a small step back from the TB specific context and talk about the standardized patient method more generally for a bit, because it is relatively new as a measurement source since about the last 10 years, being done at large scales and for these kind of complex conditions. And there are always some misunderstandings in the way that we want to use this and the way that we want to understand results from standardized patient studies. So let me step into it. And it's always evolving on these fronts here. So the first question that we deal with most of the time is, why should we use standardized patients as opposed to the increasingly rich data that's out there in administrative sources, that's in large-scale survey measurement or other sources of information, right? And the reason is that you can't measure quality reliably from most of the sources of what we think of as naturalistic or observational data, right? This is because, as you can see on the slide, patient choice confounds quality measurement. And that's a really fundamental feature of almost all healthcare systems, especially ones where there is a large private sector where patients are able to, shop around on dimensions of price and quality. And the reason why this happens, why patient choice confounds quality measurement, is shown in this very simple thought experiment vignette here in the slide, right? If you're a person A in this slide, you have a mild kind of I don't even want to say illness, but a kind of complaint. Maybe you didn't sleep well, right? You feel a little bit fuzzy. You feel, it's not my best. What does that person choose based on their perception of their illness, based on their willingness to pay for care for mild symptoms? Well, if they go to a clinic at all, they'll typically not end up at a hospital, right? They're going to choose a cheap clinic, something nearby, maybe a pharmacy. You're not necessarily looking for an extremely talented or expensive healthcare provider to treat this. You just need a couple of drugs, and more than likely, you're going to get better. So that need to balance the choice and the severity and the quality of the care comes out in this shopping process. Now, person B is not doing so well and may not be so lucky, right? They have something severe. They could have TB, they could have COVID, they could have cancer, something that really has been ongoing and severe. And as a result, they decide they're going to need high quality treatment. They may end up in the hospital. They may choose that. They may be transferred there, but it's because they've gotten themselves into a health system track that's going to be taking their condition very seriously, using lots of diagnostics to figure out what's going on, possibly ending up with lots of expensive treatment, and still ending up with potentially permanent disabilities or long-term negative health outcomes. Now, if we put this in the data set, if we just download this data set from the hospital system that's out there, or from insurance records, or from patient surveys, if we take this naturalistic data that's driven by choices over price and quality, and we do our favorite thing and run regressions on it, what are we going to find? Well, we're going to find that good health outcomes are associated with low price of healthcare, with less experience of the healthcare providers, with less spending by the health system, and with lower amounts of treatment. And I don't need to be an expert. You don't need to be an expert to know that that is completely backwards. We should almost automatically see that this type of data that's generated about quality based on outcomes, based on patient choices, is going to lead us to the wrong conclusions every time. And there's basically no way around this in observational healthcare data. So when I present a lot of results, to partners, to NGOs, to governments, we get this question all the time. So why do we have to go in and use standardized patients, which are relatively expensive, will give us a view of a very small number of clinics, interactions, and conditions, when we could just use insurance data or administrative data or medical records data from now often a very large number of patients' interactions? And the reason is it will very rarely work. It will almost always give you results that are completely backwards when patients are able to choose their own providers. And this happens across almost all domains. So this is not necessarily unique to health and medicine, but it is especially bad in health and medicine, and is especially bad in health and medicine as choices in the health sector and choices among private providers with different pricing points and with different levels of experience and professional specializations continues to expand, right? Without very special circumstances, naturalistic data will not give us the right measurements about quality. So this is what drove this kind of dynamic, this choice confounding is what originally drove the development of standardized patients, and is why we call them standardized patients, right? If you're not familiar with the method here, I'll give a quick introduction. We call them simulated standardized patients in the full in our full description, because first of all, the patients are not real people. They're portrayed by real people, but the patients themselves are invented identities. They're simulated cases with simulated characteristics. They're portrayed by people who are healthy, people who are generally working as staff or volunteers or otherwise, voluntary members of the research team. These people tend to originate from the communities where we want to conduct these studies, so that they have a natural understanding of how the health system operates, how to fill the role of a patient in that health system. And the training that we offer as people coming from the medical backgrounds and from the health systems and health policy background is how they should simulate the particular illness, right? We also work with the SPs and with anthropologists and with community members and advisory committees to develop the demographic and social backgrounds, the names, the jobs, the family life, the descriptions of the illness, but we usually teach them medical backgrounds. So when we're teaching tuberculosis, for example, versus say asthma, these have different types of cough presentations. So we work on that as well. In addition to things like if we're presenting loss of weight, getting loose fitting clothing for the person. So it's a very deep development so that a person who is not actually ill can present this illness. Now, it's even more difficult when we need to have a large number of studies because we need to have multiple people, all of whom are healthy, presenting the same version of the same illness, right? There can be variation in the background demographics. We'll often have men, we'll have women, we'll have older people, we'll have younger people. And a question we get often is range across socioeconomics, which I'll come back to. And what we do is we develop so that all the people who we naturalistically recruit will be able to present the same underlying case. In this case, TB at a specific stage, or asthma at a specific stage, or some other condition that we're interested in seeing the quality of care for. The next thing that's important here is that we are observing this from the patient perspective, right? We know part of the research design is that these people do have, right, the simulated patients who are being portrayed do have the illness that we're interested in, right? And so one thing that you'll sometimes hear is, oh, well, the provider could have treated them a different way because they could have thought they could have had something else, right? That's a very conditional statement, right? Could. From the simulated standardized patient perspective, the researchers know for sure that this person has that condition, and we see for sure whether or not they received the types of care that we think they should as a matter of health policy. Now, it doesn't mean the provider's doing something wrong if they don't do it, if they don't get the right thing. It may be that these cases are simply difficult, but we have a absolute definition going in of what the care is that's expected for the illness that we are designing to be as part of the simulated patient case. So now we have a bunch of patients who are all the same, presenting an illness that we know. The next part of the simulated standardized patient design is to solve the problem that we set up in the previous slide of choice confound. Now, we solve this problem in a very straightforward way. We simply have the same patients go to all of the providers who we are interested in observing. This solves that problem because, excuse me, in the previous naturalistic example, our underlying confounding is a problem of counterfactual hypotheticals. The same person, those same two people, could not be observed switching positions. And that's where we would actually get accurate measurement from the naturalistic data. If the very sick person went to the pharmacy and had worse outcomes in the counterfactual, and the mildly sick person went to a hospital and got no better outcomes in the counterfactual, then our measures would line up. We would see that better outcomes when we had the correct counterfactual, which is the same person presenting the same illness. their outcomes would change, would get better as they received more expensive, more specialized, more intensive care, right? The problem is that those two people are bad counterfactuals for each other. And that's solved by the simulated standardized patient because the case that is being presented, the patient who is being presented, becomes their own counterfactual across different providers in the way that is necessary to get those accurate measurements across groups, right? So at this point, we now have a way to observe a large number of providers providing care for the same simulated patient seeking care for the same condition. Doctors won't know that they are being observed. They won't know that the patient is simulated, otherwise it becomes a different problem. We've actually had a recent piece come out now on the ethical work of doing this in both Western contexts, in global South contexts, in other contexts. The use of simulated standardized patients with deception and with waivers of informed consent is commonly accepted in US and Canadian IRBs, but obviously faces both technical, legal, and ethical challenges and complications as we go beyond that context. We have an article about that, myself and Ada and a number of others. And this is very, very useful for us to dig into, and we present a lot of empirical experience working with the consent process and working with the actual ethical considerations as we develop this. So once the provider gets to these places, we observe the entire interaction with the provider, and we are, as a result, able to collect a lot of information about what happens during the diagnostic and treatment process. This is preferable to the realism for these reasons, right? We can observe the same patient at different doctors, comparing across doctors. We can observe different patients at the same doctor, right? In a way that answers a research question about how the presentation affects the quality and the outcomes. And this is the reason for setting up these counterfactuals, is that we can compare across different dimensions, across doctors, across patients, or across other dimensions, which I'll get to in a minute, when we can see the interactions that the real people would choose not to have, right? We're setting up specifically the situation where patients serve as their own counterfactuals. And this comes from the research control over the place, the provider, and the patient. So we've set up this model where we're looking at the interaction of a number of these inputs, and we're deciding which are able to be held constant and compared across, and which aren't, as part of the research design. The other strength here is that we never have any missing observations, because the researchers control the sample completely. So it turns out that much smaller numbers of observations become sufficient to answer research questions in a strong way, whereas in a naturalistic observational setting, you would think tens of thousands, hundreds of thousands of observations. Standardized patient studies work under normal RCT scales, and so become powered for one research hypothesis at around 400 or 500 interactions. So they're very efficient for targeted questions. And that is due to the strong standardization, the strong targeting, the strong design aspect of the standardized patient method. And as a result, we can ask very specific questions and answer them with normal, what I think of normal RCT numbers of observations. So these are all studies where we have just a few hundred observations, and we can get reasonable precision on key questions by changing presentations. And that list of questions has only continued to grow, right? We can ask questions about comparing across genders. We can ask questions about prices that are charged and access to different services based on the person's presentation, their socioeconomic background, et cetera, their location. We can ask about the quality of medications and laboratories, because we see which ones are recommended and given. We can look at new technologies. We can look at the people's actually perception of the provider. And then we can also do RCT style things where we look at the effects of interventions. So this is broken down broadly into 4 kind of study categories. I'm sure there are many others, but these are the ones that we've kind of used so far to date to get interesting measurements. So the first is just cross-sectional variation, where we take one presentation, hold it constant, and just see how things are different across clinics or across providers, right? So here is a slightly older study where providers often do dual practice in both public and private sectors. All the researchers did was make sure they observed the same provider at their public sector practice and at their private sector practice. The same person performed and behaved very differently, in fact, much better in their private clinics than in their public clinics in this situation. So we're just looking at variation with no intensive intervention. And we can compare across sectors from this very top level, very simple comparison in a way that you're not able to do using the naturalistic data because of the choice dynamic. This is a correct comparison between the person's behavior. Another one we can do is change the presentation, right, at the same provider. So here are options where we send, an older study sent people who said that they would buy medicines at the clinic versus that they would not buy medicines at the clinic. And the people who said that they wouldn't buy medicines from the provider were prescribed far, far fewer antibiotics, right? They're looking at incentives here for prescription. Another one we did using changing gender presentations. We just sent men and women to the same group of providers and compared outcomes. This was in India, where we thought that there would be a large gender differential in treatment, and we found nothing. But we're able to do that simply by changing the identity of the presentation among the group of providers who were in the sample. We can also use natural experiments, so things that are changing in the background, whether it's policies, whether it's environments, any number of things. In this one, we just looked at the difference between morning and evening shifts, which is very common, particularly in Mumbai, India. There's a daytime shift and a post-work shift, basically, for clinics. And we observed across the board that the quality of care, remember, these are the same patients going to the same clinics, decreased pretty significantly in the evening presentation across a number of different tuberculosis presentations. So this has consequences for people who are working during the day and seek care in the evening, right? We saw about something like a 25% decline in the likelihood that they would get through diagnosis in the evening shift. Again, same patients, same clinics, and that's the strength of the study. Now, the fourth takes us back to the interventionist health policy world. We can train providers, we can put in policies and incentives, we can change the composition, we can provide nurses, we can provide community health workers, whatever we normally do, and just measure that with standardized patients. This works very well, just the way you would expect. And in this case, we saw training among informal healthcare providers in rural India increasing skills with the amount of training received, almost up to the level of public providers in some cases. So we can do, again, very clean measurement with relatively small training samples. We can do blinded to conditions. The whole thing ends up blinded because the providers don't know when they're being observed. And we think that that's very clear. So there is lots more work to do. First of all, we need to change some views and perceptions that SPs are not poor imitations of real patients. They are not intended to substitute for missing real data and cannot be substituted by increasing amounts of administrative information. But they're very cost effective for specific questions. And we can improve the questions that we ask as well. And that we leave to all y'all who have excellent ideas and excellent questions. So with that, thank you very much. And I'll pass it back to Ada for the next section.
Thanks so much, Benjamin. So now we have a nice introduction to what standardized patients are, how they are individuals from local communities who are recruited and trained to present a set of symptoms to healthcare providers. And that can become documented, what occurs in those healthcare settings, and become our quality of care data. And so it seems like it's a very agile method that results in data that we wouldn't be able to see in healthcare records, for example. So now let's see it applied in a difference in a specific setting. And so I'll turn it over to you, Dr. Bonnie.
Okay, thank you, Ada. Apology for turning off my camera because my internet is not so good. I was like removed accidentally before. So apologize for that. Okay, I will share my screen. Okay, so first of all, thank you so much for the opportunity. So I can share our Indonesia SP study and what we have learned about the quality of TB care in Indonesia. So my talk would be around TB management challenges in Indonesia, especially in private sector, our current tuberculosis diagnosis algorithm, and how we conduct the standardized patient study. And I also present the comparison of the SP study because we have like a two kind of snapshot in 2018 and 2021, and what we have learned from this SP study result in Indonesia for further inform the policymaker. So of course, from our, Indonesia is a country with high burden of TB, and there is an assumption that a lot of missing cases happen at the private sector. And the patient pathway study firstly conducted in 2017 showed that 54% of TB patients sought care at the private practitioners. And further, we also confirmed in 2020 that there is still a lot of patients start seeking care at private sector or informal provider, and almost half they start treatment in the private sector. And also in a large survey in 2015 with Mahendra data, it's also say almost the same thing, like actually not all private GP have seen presumptive TB. So usually the volume seen per month is quite low. And there's also a considerable proportion of this private GP, they not utilize smear microscopy. So at that time, we are not yet adopting the WHO rapid molecular diagnostic. So we still use the smear microscopy. And then most of them, they are not aware of ISTC, and the majority haven't undertaken ISTC training, and very few link to the NTP network. So this is something altogether really concerning about how they deliver a good quality of TB care in Indonesia. So currently, since 2021, our national TB program mandated the use for rapid molecular examination for TB diagnosis. So in Indonesia, mostly we use Gene Expert. Yeah, so as the background in our setting, we conducted like 2 per-sectional study of this standardized patient. So first, we called the InStep study in 2019. The data collection lasts for 1 year, and then also the COVET. So this is the second SP study we conducted during COVID-19. So the location is the same between these 2 studies. So this is the 36 randomly selected area, Puskesmas area in Bandung. So the method is unannounced SP visit. So we managed to get ethic approval, like a waiver that we don't need to inform the private practitioners that we're gonna send SP to their clinic, because we argue that by asking their permission that they might change the behavior. So in the previous SP, we have 4 different scenarios. And for the COVET study, we only have 1 because of because it's in COVID, it's more challenging. So we just send presumptive TB in the context of COVID. So for the analysis, we compare the real practice of the physicians with regard to the what we assume as a correct management, like Do they order expert test or smear microscopy? Do they refer the patients to public dot center, or do they ask for other examinations for TB diagnosis like chest X-ray, culture, or DST, and also the pattern of the referral? So in terms of the provider and the qualifications, so most of our physicians is mostly female. We capture in these two cross-sectional, and most of them are GP. It's quite difficult to find specialists here that we can send for SP. And then most of the physicians also work at the private clinic, either private clinic or private hospital. So only 1/3 they provide solo practice. And some of these healthcare facility, especially the private clinic, they also provide pharmacy and like mini laboratory. And some of them, they also have X-ray, but only very few provide sputum examination. In terms of linkages with the health sector, there is not that difference. So most of them, they don't have a good, they are not linked to the national TB program. So which means that they might not have SITB, or they don't have a system where they can report if they have TB cases, either TB diagnosis or TB treatment. And since 2019, we have upscaling the National Health Insurance Scheme, and it seems that it's the number of the private providers engaged to this universal health coverage is increasing. So this is also highlight the importance that we need to like invite these private practitioners on board, and then in the context for the national health insurance. And I think this is something that's happening in Indonesia, that we try to incentivize these private providers for TB program. And in terms of the clinical history taking and also the management, the prescription pattern, we still see two major practice here, that a lot of the private practitioners, they prescribe non-TB antibiotic. It's just like quite common. And then also like 1/3, they still also think maybe this is like allergic or something. So they prescribe anti-inflammation, especially the corticosteroid. In terms of TB diagnosis method, so this is very clear that these private providers choose over chest X-ray rather than microscopy, either AFB or expert. It is very quite surprising. We have the algorithm, but still most of these private practitioners, they are not aware of the newest method for TB diagnosis. So this is also giving us flag for intervention. So when we did this SP study, we learned that there is a high physician turnover. So at the beginning, we really hope that we can have like batches, a cohort of physicians in Bandung, but it seems that only 20% stay. So for example, like TP in 2008, it's only, we can found 20% of them still providing services in 2021. So it's very high. So new physician coming to this sector. And we also experienced that one of our SP finally get TB. So this is also highlighting the importance here for infection prevention control among our SP. But I also highlight something we learned from these two study is that with regard to the limitations, conducting SP study is resource intensive. So I have to do audience to around like 50 actors. And then I have to select those with mimicking TB patients, skinny patients, for example. And then, yeah, something that is really look like real patients. It's really challenging, and we have to train them very well so they can deliver the case well, especially if we have 4 scenarios. So we need to make sure that they don't mix up with like scenario 1 with 2, 2 with 4, etc. Of course, with real patient, we likely see more variation, I think, in how patient and the physician behave. But yeah, and we also learned that this method doesn't allow for repeated visit. So we can't observe how provider would behave if the patient returned for a second visit. For example, if the doctor think, oh, this patient might have TB, I will first give antibiotics. And then if the patient doesn't getting better, the patient can come, and then what would be the patterns of clinical decision-making by these doctors? So that's something that we don't observe. And only provider who consent. So in Bandung, it's quite difficult because we don't have a strong data about the availability or the existing of this private practitioner. So we need to do a mapping at the beginning. And because we need to do this first, and only maybe 40% of the provider included, then we can send the SP. So maybe this is also a potential source of selection bias. But I also highlight several strengths of this study. I think this is a perfect method, as Ben explained, that describe doctor preferences without bias, because I can see many variation on how they choose diagnosis or treatment pathway for presumptive TB cases. And then, yeah, we can describe TB management pathway in reality. And this is also an efficient way because one SP can visit multiple providers with multiple scenarios. So this is also an advantage having this SP study. And we can also identify the provider no-do gap. Okay, I think this is the end of my presentation. Thank you for listening, and I would like to give the floor back to Ada. Thank you.
Thanks, Dr. Bani. So that was a really great presentation showing how different SP case scenarios can be developed and implemented, as well as how correct management outcomes are defined that link to the SP case. That was also really interesting to hear how resource intensive this method can be and how consenting challenges can also occur. But after implementing, it seems like tuberculosis management, you can see it in reality, and then you can also see all the variety of diagnostic and treatment outcomes for presumptive TB symptoms can occur in reality as well. And so now linking it to informing quality of care and provider perspectives, I'll turn it over to you, Angie.
Great. Hi, everyone. I'm going to share my screen. All right. Hopefully that is looking okay for you all. Yeah, I wanted to thank all of my colleagues on the panel for what they've shared so far on the value and the strength of standardized patient studies and what we have seen on the ground with the example of Indonesia. So what I'm going to be speaking about is how can we interpret and learn from these studies, and I'll be drawing on my experience conducting these SP studies, but also my background in quality improvement to think about how we might be able to use SP studies to inform and guide improvement efforts. So let's say that after today's presentation, you've been fully evangelized into the idea that we need to use standardized patient studies to have a good measurement of the quality of care for TB. And we've heard about from the other presenters about how to do this, some examples, and you've done it in your context and you have your results. What's next? So the strength of the SP studies, as we've been talking about, and as Bonnie pointed out at the end of her slides, is that the SP studies teach us about the no-do gap, which we can characterize as the failure to translate what is known to work into the care that patients receive. So what does this mean for TB programs? As Ada pointed out in the introduction, this gap between what we know works and what we are doing means that it takes longer for people with TB to reach the care they need. It results in worsened disease and increased potential for infections. And SP studies provide us with in-depth knowledge about this no-do gap, the magnitude of the gap, so how far away is provider practice from what we know works and what we expect practice to be. And then also which types of facilities or providers are affected most. Bonnie talked a bit about the difference in sort of looking at general practitioners and specialists. And it also offers us some ideas for specialized or specific areas for improvement. So now that we've conducted an SP study and we know more about the size and scope of our no-do gap in our context, the next step is to try to close that gap. So I'll give an example from some of the work I'm familiar with of how to use SP results to improve quality of TB care. So an SP study was conducted in 2019 by the SHOPS Plus program that is supporting supporting strengthening health outcomes through the private sector. Thank you. Which is USAID program, and Lauren Rosapep was very much leading this with other colleagues. So the SP study conducted in 2019 in Lagos and Kano, Nigeria, found that SHOPS Plus supported providers in 47% of SP visits conducted inappropriately dispensed or prescribed antibiotics, fluoroquinolones, or steroids. So SHOPS Plus team acted on these results by implementing targeted interventions to improve the counseling and treatment initiation skills of network providers, and by developing information, education, and communication materials for patients and job aids for providers. So these activities happened after the first SP study, and we then conducted a second SP study in 2021 that showed that this same percentage of inappropriate dispensing or prescription dropped to 22%. So that's just an example of how, the gap shown from the SP study was then acted on by the team to inform the program activities. And then we saw a change in some of the results. So there are a number of different methodologies out there that can be used for improvement, but I'll spend a little bit of time going through just a quick example of something from quality improvement that can teach us what to do with the results that we see. So just quickly, the model for improvement, which was created by Associates for Process Improvement and is used a lot by the Institute for Healthcare Improvement, IHI, consists of 3 main questions and a plan, do, study, act cycle to test and adapt changes to ensure they result in the desired improvement. So the first piece is, what are we trying to accomplish? And that refers to setting an aim. An aim, rather than saying, we want to improve private provider engagement, or we want to improve connection of private providers to the NTP, you would want to have an aim that's specific, measurable, attainable, relevant, and time-bound. And so some example would be from Indonesia, we saw just 1% of the SP visits, a provider referred their patient to gene expert services. So perhaps we want to say, increase the gene expert referral rate among private providers in, say, 5 of our sub-districts from 1% to 20% by September 2024. And that also defines what you want to do in that SMART aim, is also define the population affected by the improvement effort. So for this case, it would be private providers. You want to identify where the improvement will take place, but also importantly, to engage private providers who are the individuals that will benefit from this improvement in setting this aim. It could be that your baseline says this, you have a goal of this other number, but private providers may think, let's think about this differently. And in terms of private provider engagement, you also, if possible, want to engage patients in this as well. So after what are we trying to accomplish, the next question is, how will we know that a change is an improvement? And so we've talked a lot today about measurement in SP studies. SP studies are a research tool, but measurement for research is very different from measurement for learning. What we want from measurement is to bring new knowledge into daily practice, and to conduct that through small sequential observable tests that are centered on learning, ideally using routine measures. Of course, we know that sometimes these can be challenging, as Ben pointed out, but using these routine measures over time to see the impact of your changes on your outcome. And so there's three main types of measures. I won't go too deeply into them, but outcome measures are linked to your aim statement. Process measures are asking, are we on track in our efforts to improve the system? So say we set out to do these activities, are we doing the what activities we said we would do? And then balancing measures, of course, quality improvement aims to use the resources we already have and to shift and change those to create changes in our system. But that can often lead to issues of imbalance in the system. In some of the work we did in South Africa for, there was a South Africa TB quality improvement initiative. We wanted to focus some of the work on screening. And so we ended up having two people from the clinic screen every single person that came in for cough symptoms. And that ended up causing other issues in terms of the resourcing of the system. So you want to make sure you have balancing measures to make sure your changes aren't resulting in unintended other effects. And then what changes can we make that will result in improvement? So these are your change ideas. And some ways to generate change ideas: you want to carefully examine your existing system, explore parts of the system that get in the way of better performance, and investigate best practices outside of your organization to understand what is possible. One really interesting tool is that I want to highlight is the 5 whys. So this is asking the question why 5 times, almost like you're a child. If the question is, why aren't private providers using GeneXpert for their patients? Maybe it's like they don't have access to the NTP resources. Why don't they have access to NTP resources? And then we continue to go until we find the root causes of these issues, and then use that as ideas for changes. So linking all these 3 questions up into a plan, do, study, act cycle, the PDSA cycle, where you're running small tests of changes that can contribute to your aim. You want to start small, 1 provider, 1 facility, and make sure that these tests are happening rapidly to inform your results. And then you want to, those arrows connecting these 2 pieces are also that you want to use your PDSA cycles to provide feedback to inform your questions. So how might we use SB studies results to improve quality of care? So what we know from what we've talked about is that these results provide a baseline measurement of provider behavior towards presumptive TB patients. So we know where we're starting from, and that can be really key in setting the goal and the aim. You want to be able to narrow down your aim from your SP results. So if provider management of TB patients is off, in particular around prescribing, that would be a really good point to center down that aim. It will indicate which types of providers or facilities are most in need of improvement. And it can determine other factors that may affect provider performance. So the other factors that Ben pointed out, pieces that could affect care, like wait times or the number of patients that are in the clinic, the gender of the patient, those kinds of things will be illuminated by your SP study. And future SP studies can be used in tandem with other measurement strategies to assess the performance of improvement activities. So if you have an improvement project, you start with a standardized patient study to get your baseline, you conduct your improvement project, you're tracking your measurements as you go, and then perhaps you end up at the end with another SP study to see if your changes resulted in changes in quality of care. So this is just an introduction to get you all thinking about how we might be able to use these results to improve care and to translate that knowledge we get from SP studies into practice. There's a lot of different resources. The KUTU project, which Ben and Ada and others were very involved in, have some really great resources on their website, including a quality improvement handbook for TB and MDR TB programs that was developed through the TB Care 2 USA project. As well as the toolkit of how to use standardized patients to measure healthcare quality. And that's your main resource for how to conduct these studies on your own. When it comes to quality improvement, I'm putting my alma mater out there of the Institute for Healthcare Improvement, has a lot of great resources on how to improve, many of which I drew from for this presentation. And then quality improvement is just one example of an implementation science strategy of getting evidence into practice. And that the implementation science group at University of Washington in Seattle has a great deal of implementation science resources, especially targeted for more low and middle income settings. So that's all. Thank you all, and I'll hand it back to our moderators.
Great, thank you, Angie, for walking us through a little bit of how you can actually use SP studies. As somebody that's been involved in an SP study, that is definitely the first thing that you start to wonder about. And certainly the reason that you do SP studies to begin with is to understand quality of care. And so then that naturally does lead into a whole quality improvement process, of which there are many different ways to go about it. I think an interesting point that you brought up is that SP studies, you might think, oh, we just have to keep doing SP studies. And as Bonnie pointed out, these are expensive studies and we don't always have resources for them. So hopefully everybody kind of picked up on some of the points that Angie was making just around that. Just because the SP studies give us a sense of where we need to go, where the problems might be, it's not just a repeated use of SP studies that can help us continue to improve quality in the future. So they really work well with a whole suite of techniques and quality improvement mechanisms, not all of which are super expensive. So just in case you're wondering about that. But just to kind of shift over to some of the questions that have come up in Q&A, and this is for the panel in general, is first we got a question, I think, about kind of application of the SP approach in other contexts. So we've been talking about using SPs in a clinical setting. And there was a question from the audience about whether there's room or opportunities to apply an SP model in other intervention contexts. So the audience was asking, a member of the audience was asking about whether you could use an SP model in a community education or communication intervention. And I'm curious, from those of you that are real experts in these interventions or who've done these studies before, what your thoughts are. Bonnie, Angie, Ben, or Ada, I'm sure you all have some thoughts.
Sorry, could you be a little more specific with the question?
So the specific question from the audience was whether you could use an SP model to test the effectiveness of health education in a community setting. So again, like outside of the clinical setting, is SP an appropriate?
Yeah, so the closest thing we have, obviously the difficulty here that extends pretty broadly, is that we don't observe, what actual care seekers do in terms of in interacting with and negotiating with the provider. So the hard part here, and I was getting this towards the end of my presentation, is that we need bright questions like this. The closest we've done is Ada and I worked on an intervention where we knew that providers were being issued vouchers to cover the testing for this kind of TB testing for the gene expert stuff, specifically when it was first being introduced in India. So what we did was we had two versions of the presentation. In one case where the SP was trained to say, if they were offered one of the covered tests, they were supposed to say, oh, I heard this could be got for free if they didn't receive the voucher. And that did induce providers to go back and say, oh, you're right, I do have the vouchers for this. So this is a very limited kind of application because you have to have an idea of what the alternatives would be. But it can help you say what kind of education might work more so than the other way around. Did education work? Because we can't test whether actual care seekers take up the thing, but we could say which ones influence provider behavior. So I hope that helps. I know it's a bit tangential to it, which is why I asked to clarify, but that's what we've been able to do so far.
Great, thanks, Ben. Any other thoughts on this question from others on the panel? Okay. So another question that we are getting from the audience is around a little bit of kind of what do you do if an SP study tells you that there is substandard care? And perhaps all of you can draw from your experience in terms of, I know from my experience working on SP studies, there's definitely going to be data that you get that shows you that you have substandard care. So the question is more around what have you seen happen directly in response to some SP studies? Do you immediately try to fix the protocol or the policies, or is it a little bit more dialogue and exploration of what some of the root causes are, like Angie was talking about?
Angie, do you want to?
I was going to bounce it to Dr. Bonnie, but if you have examples, Ben, go for it.
I mean, I don't have as much specific examples, you know, aside from what we've done in the kind of Good to project. Again, myself and Ada, this was all part of that quality improvement project. But, you know, to say that, you know, we go into policies and protocols, I mean, remember, at least I have worked largely with private sector providers. So policies and protocols isn't a, you know, lever of action necessarily. So what we end up with, right, is the kind of broader social science framework of first describe, you know, what's happening, the quality of care, like, is it bad? Sure. Then try and predict the quality of care, say what kind of characteristics and presentations and providers are associated with poor quality of care, and then try and control it, right? So it's actually quite far down the stage of the social science model of describe, predict, control that we actually have, you know, interventions into this. Because intervention is costly, it's difficult. There are a lot of like attenuation in the kind of causal theory of change that we need to actually make improvements. And so there's a lot of time spent doing the middle part, right? So once we've described that quality is poor, we spend a lot of time trying to predict where and when is it going to be poor versus where and when is it going to be good, and figuring out how to either get rid of the interaction classes where quality is poor, move people from the classes where it's going to be poor to where it's going to be high quality, or increasing the size of the high quality pool. So there's a lot of different possible approaches. And so we spend a lot of time in that middle stage trying to predict how the different low and high quality interaction types come about. And then only when we have a really good grasp on that and what the costs and stuff are going to be, do we start doing stuff that's intervention, you know, trying to control those outcomes.
Great, thanks.
I'd love to, oh, sorry, Lauren, I'd love to jump in on this as well. I think part of one of the strengths of SP studies is that the results that you get from these studies, what's very important next is to make sure that all those who are sort of stakeholders in this system are informed of the results, you know, and that is the first step to say, hey, everyone, you know, we did a study of private providers in our setting. This is what we saw in terms of the gap in appropriate care, and getting everyone to sort of be on board with this is a problem that we need to work together to solve. And there's you know, there's measurement for judgment, there's measurement for learning, and a little bit SP is sort of that measurement for judgment, but it's judgment that can then hopefully improve the system. And I think Dr. Bonnie, we've recently just shared the results of the SP study in Indonesia, but I'm wondering if you can share any examples that you have of how these results might have prompted some changes in the system or some ideas for changes.
Yeah. So from Indonesian's experience, it's really like we have like two snapshots about the practice of TB diagnosis and treatment in the private sector. And I honestly have to say it is quite, for me, it's really sad result. I mean, because we don't see many changes since the surveys in 2015 and then 2018 and 2021. So this is this SP study, I would say, is very important because we keep seeing the same thing, and this is very important for us to work together. Like in Indonesia, we need to work because there must be a reason why we have this kind of situation. So we did a follow-up qualitative study among private practitioners, and we found actually this is not really as simple as we think. There is like a lot of things tangled together, like guidelines factors. We found that quite like we don't only have ISTC or WHO, we also local guidelines and professional organization guidelines. So in terms of implementations, doctors can be very confused how to really translate this. So that is captured in the SP study because we see variability in the diagnostic and treatment pathway. So yeah, and the good thing about this SP is that then we can highlight which changing and whether the change is in a better directions. And it's very important to have a close collaboration, I would say, with the local health office, with the stakeholders, I would say, the local health office, or with the professional organizations, how we can improve this. But it is really highlight that beyond this result, there is like health system thing going on that we still need to improve. So it's not only the private practitioners, but it's also the healthcare delivery, the financing, the regulations, all the 6 WHO building blocks play a role on that. I think that's my take-home message today, doing this SP study in Indonesia. Over to you, Lauren.
Thanks, Bonnie. Yeah, I think your point about that in some ways the SP studies, the answers then open up a whole world of possibilities where you might have to, and there may be implications for all different health system building blocks that you need to address to improve the problems that you're seeing coming out of the research. Building on that a little bit, we have a question around the role of routine measurement for quality. So we've all spoken a little bit about how SP studies could be used in a routine way, except they are they can be resource intensive and do represent a certain setting where it's one visit over one period of time. Wondering if you, Bonnie, or Ben, or Ada have any other suggestions for how SP can be used as a routine measurement, if at all, or whether there's other routine measurements for quality or routine approaches that should be used alongside an SP study to inform and kind of drive quality improvement over time.
Yeah, I mean, to go back to the program that, Ada and I worked on, the one that led up to COVET in India was a 10-year, measurement of care quality in the private sector in urban India. So a very difficult place to do routine measures because there is nothing else. There is no source of information. So SP's made a very, very good, routine measurement system there. SPs are only really expensive the first time, right? An enormous amount of our costs in that study, and Ada, you correct me if I'm wrong, you did a lot of the budget math. I would say probably half of it was in the setup, in terms of, our time developing the provider sample, training the original supervisors, developing the cases and the protocols, working with the experts to get the definitions of correct management and medicine expectations. There's a huge amount of startup expenses to learn a new environment. But then every time we went back, we did 4 rounds of SP measurements. The subsequent years are very inexpensive because you know who you're going to, what cases are being presented. We carry over a lot of the same staff in that case because it was an ongoing study. And so doing it in a routine way is actually incredibly affordable if you can maintain the program, right? And so we had tried to pitch that a number of times outside this, but it's outside that study. It's very doable. I would love if Ada had any thoughts on that, but it's incredibly doable, incredibly efficient, if you have the commitment to a long-term program.
Yeah, just to add on to what Ben was saying, I think the linking between the previous question and this one kind of goes together, where if you are in the context, if you're running SP studies in the context of a larger program where there's other stakeholders that are involved with either implementation or making policy and designing those types of aspects of the program itself, rather than the specific research measurement component, you may have the resources to do it more routinely. I think in the COVET project, which we didn't talk about that very much today, but it was ongoing for several years in 3 different cities in India. And I think we did learn in the context of a program which was changing a lot of the dynamics of vouchers, treatment and diagnostic vouchers. I think we did learn that quality of care does not change very quickly at the larger level. And so it's not as though you would need to do a standardized patient study 1 week and then the next month do another one. You're probably not going to get changes in quality of care for 6 months, even with larger incentives happening in the market, maybe even slower. And then if you're interested in measuring like a technology adoption, maybe like Gene Expert or something, if there's a larger efforts happening with education or sensitizing and marketing for those technologies, maybe you might want to monitor it, but probably not as frequently as like 3 months or so. I mean, it's a trade-off with how much budget you have and how many resources you have and what else is happening. But I guess if there's specific situations, you can reach out to us and we can provide an informative answer. I don't know if others to jump in.
Well, I'll just mention, because we know we got a question in our email before this presentation just about resources and guides for how to actually conduct a standardized patient study, which can kind of help feed into how can you make this a partially routine piece of your quality improvement puzzle. And we'll be sending out, so for one, the COVET project has developed a lot of resources that I've used personally in my own studies that are very helpful for getting started with this kind of work. And so Petra will be sending out in a follow-up email some links to those resources for all of you to see, and contact information for people that have been on this panel here. So if you have more questions, certainly look at those resources. We are almost out of time, but before we leave, I know that one of the participants in our discussion today is actually a former SP themselves, Zinle Mtwane from South Africa. And I believe they're on this call and also now working in health research. And if you are on the call and interested in providing any short reflections about what it's like to be an SP and then now moving into the health research part of the world, we'd love to hear your thoughts. But I don't know, Petra, if Zinle would be able to get off the mute at all. And if not, we'll just recognize her contributions.
I moved her into the panel. So Zinle, if you want to speak for a second, we would love to hear from you, but it was hard to prompt you. So thank you so much for joining. If you don't want to talk, that's also fine. We really want to just highlight you. She's in the panel at the moment, but I don't think she's unmuting. So.
Oh, okay, great. Well, it's all to say we're really happy to have an SP standardized patient, somebody that's actually done the really hard work. It is very hard to be an SP. It takes a lot of patience and time and training, and they do such a great job to generate such useful and rich information for us. So we appreciate Zinle's contributions. We are basically at time, but just if we can get a few final, one sentence kind of final remarks from each of our panelists. And again, there'll be resources coming out after this. We wrap up today, but maybe we can start with Ben for sort of a final thought, and then we'll go in order from Ben, Bonnie, Angie, and then in Ada too. You have also always some great thoughts.
Sure. No, I mean, I just want to echo what Ada said, just in her last comment, which is that I think, there's some thought of, SPs kind of being a research method. But I think that the future is absolutely using this more and more, as a, integrated in policy changes, integrated in routine measurement. There's a huge amount of space, for using this as a routine tool and not just to the area of kind of like one-off research questions, and that's something that we are more than happy to help with, and our contact information is available, our resources are available, and we are happy to work on those programs. And I see that absolutely as the future going forward, because of the efficiency and targetability of the method. So yeah, thank you all very much. This has been great.
Great, thanks, Ben. Bonnie?
Yes, I echo what Ben said. So I'm a fan of SP study. So SP approach is beneficial, I think, for TB program. If you can do and you can include this as part of measuring the quality of TB care, that's very important. And again, this also a homework how we can link the result to the policymaker and make some changes on that. Yeah, over to you, Aaron.
Great. Angie, any final words?
Yeah, absolutely. I think what Ada said at the beginning of the session still rings true. What we cannot measure, we cannot improve. And I think there's so much power that can be harnessed through the work of standardized patient studies, as well as the work of quality improvement. And linking those two activities together, I think would make a really powerful implementation situation. So excited to hopefully learn from all of you in the future, and from all of those on the call that are doing the work on the ground. We hope that you can take up some of these ideas that we've talked about today.
Great. Thank you, panel, for all of your thoughtful remarks and answers to the questions. Petra, I'll hand it over to you for some final remarks and kind of wrap up.
Thank you. Thank you to the fantastic panel. I've learned so much. I appreciated each of your presentations very, very much. And I think they were incredibly informative and thoughtful and well put together. So thank you. Thank you to our wonderful moderators who kept us all on track and who brought the questions in. And I want to thank the audience for some great questions. Keep it coming. We will respond as was already mentioned. We will put a report together, which will probably be out in the beginning of next week. It will be on our website. We'll also post it on social media. You will be able to find it in our news section, and it will include all the wonderful resources that have been shared today. We will make a long list of background materials so that you can do any further reading. And please reach out if you want to get in touch with any of these wonderful panelists. We would be happy to put you in touch because they are fantastic resource people that you can really reach out to. So I encourage you, if this is a field of interest, please do reach out. And with that, I would like to announce that we have next Friday, the 16th of February, we will be talking with a group of people that are affected by TB about quality of TB care. So it leads nicely on from this discussion that we've had here, and we'll be looking specifically at the area of social support. And what type of social support do people need while they're in the process of going through treatment? And what kind of social support do private providers give? And so we'll follow a little bit on the quality of care issue here that you've brought up, and we're looking forward to having that. So tune in for next week. We will share links and everything on our regular channels. And thank you so much, everyone, for today. And have a wonderful rest of the day, and we'll see you soon. Thank you.